Okay, we talked briefly about the stress response. So the stress response really has two components. There's the neurologic and the hormonal response. So the neurologic response pretty much takes into account a number of areas of the nervous system, and then the hormonal response is really intimately intertwined with the neurologic response. And the most important stress hormones really are CRH, ACTH, and cortisol. Cortisol being kind of the active hormone in this cascade. Remember, CRH from the hypothalamus controls the release of ACTH from the anterior pituitary, which controls the release of cortisol from the adrenal cortex, as well as the catecholamines. So the catecholamines, the most important ones for the stress response, are epinephrine and norepinephrine. Dopamine is also a catecholamine. And this is just showing pretty much what I just said. CRH from the hypothalamus, ACTH from the anterior pituitary, cortisol from the adrenal cortex. Okay. This is a little misleading. So they're just showing that this is the adrenal medulla, but cortisol is coming from the cortex. Okay, then we talked about damage to the hypothalamic pituitary axis can be caused by a number of things. Almost anything can cause damage here. So, lack of blood flow, a hemorrhage, infection, tumors, you name it, it can cause it. So hypopituitarism, this refers to just decreased action of the pituitary. Okay. Panhypopituitarism, this really refers to a widespread decreased secretion of pretty much all of the pituitary hormones. And these terms really mostly refer to anterior pituitary hormones. And then hyperpituitarism, this refers to excess secretion of pituitary hormones. So we talked about acromegaly. I think it was our first lecture when we talked about too much secretion of growth hormone in adults. So that's an example of hyperpituitarism. This is just showing that knowing our relationship between the hypothalamus and the anterior pituitary, if we have decreased hypothalamic function here, we're going to have decreased function here. So, other mechanisms of altered hormone function, so the big three: damage to endocrine glands, damage to cell receptors, and damage to feedback mechanisms. So, damage to endocrine glands. So, if there are any sort of genetic defects or infection, autoimmunity, trauma, things that can damage endocrine glands, that's obviously going to alter their function. Now, damage to cell receptors, if you have a decreased number of receptors or a decreased sensitivity to a hormone by the receptor, or blockage or stimulation via antibodies, that can definitely alter hormonal function. We'll talk about that with type 2 diabetes and when we talked about Graves' disease. And then damage to feedback mechanisms. So if there is a tumor, sometimes tumors will secrete a hormone ectopically. This can actually override feedback mechanisms. So it's producing hormone like crazy, and feedback just doesn't keep up. So the first disease we talked about was SIADH, which is syndrome of inappropriate antidiuretic hormone secretion. And this is hypersecretion of antidiuretic hormone. Okay, typically caused by ectopic production of ADH from tumors, but it can also be due to a number of other things. So obviously, antidiuretic hormone increases reabsorption of water in the kidney. So obviously, we're going to have excessive water reabsorption in the kidney, and water actually accumulates inside cells first. And then once that phase passes, then it starts to increase in the extracellular fluid. And when it does this, you have dilutional hyponatremia. So some clinical manifestations: thirst, obviously decreased urine output. The urine will be highly concentrated, loss of appetite. You typically won't see peripheral edema, at least early on. And then any sort of symptoms associated with the hyponatremia. So diagnosis and treatment. Diagnosis is going to be based on hypoosmolarity of the serum. Okay, we're holding on to water, so we're diluting essentially the blood. Urine hyperosmolarity, obviously the urine is going to be very, very concentrated. And then normal thyroid and adrenal function will help to rule out other causes. And then treatment, correct any underlying cause. And then possibly medications. So this is just kind of summing this up. Okay, then we talked about diabetes insipidus, which is kind of the opposite of SIADH. And there are really two types of diabetes insipidus. So diabetes insipidus, you have insufficient amounts of antidiuretic hormone. This is called neurogenic. Or an insufficient response to ADH in the kidneys, and that's called nephrogenic. But both types are going to cause polyuria and polydipsia. So brain lesions, so any sort of lesion of the pituitary or even the hypothalamus can cause the neurogenic types. Kidney diseases can cause the nephrogenic types. And obviously patients will not be able to concentrate their urine. So clinical manifestations, as I said, polyuria and polydipsia. The urine will be highly, highly dilute. Nocturia, getting up to go to the bathroom. Serum hyperosmolarity, so as you're losing water, the relative concentration of the solutes in the serum will increase, so you'd expect hyperosmolarity, and dehydration, typically pretty severe. So diagnosis, symptoms, so obviously the polyuria and polydipsia with the absence of diabetes mellitus, increased urine-specific gravity, decreased urine-specific gravity. So specific gravity just compares basically the density of urine to the density of water. Since this urine is very, very dilute, it's going to be very similar to water, so you would expect a very low specific gravity. Blood testing. Treatment depends on the cause, depends on how severe the disease is, as well as the age. So again, this is just summing up diabetes insipidus. Okay, then we talked about alterations of thyroid function. So hyperthyroidism is a condition of excess thyroid hormone production from the thyroid gland. The term thyrotoxicosis really refers to any condition that results in too much thyroid hormone. Okay. Now, hyperthyroidism can be primary, it can be secondary. Common primary causes, Graves' disease, which I'll talk about on the next slide. Common secondary causes, things like pituitary tumors, pituitary adenomas, things like that. So clinical manifestations of hyperthyroidism, regardless of cause, typically weight loss, heat intolerance, tachycardia, diarrhea, increased tissue sensitivity to stimulation by the sympathetic nervous system. And this makes sense because thyroid hormone, its job is basically to increase metabolic rate in virtually every cell in the body. So it would make sense that they're going to have weight loss because their basal metabolic rate will be higher. They're intolerant to heat because as metabolism increases, so does body heat. So any extra heat can be very uncomfortable. Tachycardia, obviously, diarrhea. All of this makes sense. And again, this is really regardless of cause. Okay, you're going to see this in pretty much all cases of hyperthyroidism. Okay, then we talked about Graves' disease, which is the most common cause of hyperthyroidism. It is an autoimmune disease. Basically, you have autoantibodies. I'll just flip to this slide really quick. You have autoantibodies that kind of mimic TSH, thyroid stimulating hormone. So what these autoantibodies do is they bind to these TSH receptors and stimulate the release of thyroid hormone. So a couple of distinguishing features along with all of the other manifestations of hyperthyroidism. Exophthalmos, which is this characteristic bulging of the eyes, as well as pretibial edema, which is edema in front of the tibia. More common in women, which we know is characteristic of the autoimmune diseases. Now, a thyrotoxic crisis or a thyroid storm, this is a dangerous condition where there's a sudden I shouldn't say sudden, but just a worsening of the thyrotoxic state. And this occurs most often in patients who are either undiagnosed or they're not being treated properly for their Graves' disease, and especially when they're under emotional or physiological stress. Because stress is going to increase sympathetic response, and that's just going to exacerbate all of the symptoms of hyperthyroidism. Okay, so we talked about hypothyroidism next, which is a deficiency of thyroid hormone production, and this is more common than hyperthyroidism. So it can be acquired or congenital. It can be due to deficiency of synthesis of thyroid hormone, destruction of the thyroid gland. Maybe there was some thyroid cancer or a tumor of some sort, and the thyroid had to be removed, or impaired TSH or TRH. So clinical manifestations, kind of the opposite of hyperthyroidism. So these people tend to be more fatigued, more intolerant to cold, lower metabolisms, possibly weight gain, low energy, myxedema. So myxedema is basically severe hypothyroidism or long-term chronic hypothyroidism, characterized by edema in the face, especially edema around the eyes, known as periorbital edema, poor skin, and hair quality, things like that. So Hashimoto's thyroiditis, this is basically autoimmune hypothyroidism. So if Graves' disease is autoimmune hyperthyroidism, this is autoimmune hypothyroidism. And this is the most common cause of hypothyroidism. So basically, you will have autoantibodies and autoreactive T cells that kind of infiltrate into the thyroid gland, causing vast inflammation and eventual destruction of the thyroid gland. And again, much more common in women. So diagnosis and treatment for altered thyroid function as a whole. So diagnosis, clinical manifestations, thyroid hormone level measurements, TSH measurements, treatment, surgery, possibly immunosuppressants, hormone replacement for hypothyroidism, thyroid hormone blockers for hyperthyroidism, a number of ways to treat it. And this is just showing clearly myxedema here, which is severe hypothyroidism. And then this is just a little comparison of hyperfunction versus hypofunction of the thyroid gland. Okay, then we talked about Cushing. So Cushing syndrome versus Cushing disease. Cushing syndrome, this just refers to the clinical manifestations that you attribute to too much cortisol. It does not matter what the cause is. Okay. Cushing disease, this is specific. This refers to too much ACTH being secreted from the anterior pituitary. Okay. So they are similar, they're related, but they're different. So some causes here, at least of Cushing syndrome: excess corticosteroid use. So if people are taking corticosteroids for a long period of time, they may develop Cushing syndrome. Now that is not Cushing disease, that's just Cushing syndrome. Pituitary adenomas, this can result in Cushing disease and then Cushing syndrome because you would have the clinical manifestations. Diseases of the adrenal cortex, dysfunction of the hypothalamus, possibly tumors that produce ACTH ectopically. As far as clinical manifestations, so kind of the hallmark signs here are moon face and buffalo hump. Also truncal weight gain, so weight gain around the midsection. You'll see wasting of the limbs, thinning hair. They tend to bruise very easily. You may see hirsutism in women. So a number of clinical manifestations. So we showed these pictures here. Patient before, patient 4 months later. This is clearly Cushing syndrome. So diagnosis and treatment. So diagnosis is really a 24-hour urinalysis, which will basically show too much cortisol being excreted. Now there can be false positive states. For example, the obese are in a chronic inflammatory state, so they often produce too much cortisol. Anorexia and bulimia, alcoholics, all of those can result in false positives. And then treatment is just removing the cause. So if it's a pituitary adenoma, maybe removing the tumor. If it's oral corticosteroids, trying to find a way to get off those corticosteroids. And a lot of times you can get back to your pre-Cushing state if it's caught soon enough. Okay, then we talked about Addison disease. So Addison disease is also known as primary adrenal insufficiency. And this is a generalized decreased function of the adrenal cortex. So the big things here are decreased cortisol production and decreased aldosterone production. Like I said earlier, there are some sex hormones that are produced from the adrenal cortex, but it's very minimal when compared to the testes and the ovaries. So we're really going to focus on cortisol and aldosterone. So it's usually caused by autoimmune destruction of the adrenal glands, but things like TB and other chronic infections can also result in destruction of the adrenal glands. So clinical manifestations: fatigue. So energy balance is off because of that loss of cortisol. Hyperpigmentation and vitiligo in some cases. Hyperpigmentation is actually a pretty important find when it comes to Addison disease, and that's just because melanocyte-stimulating hormone and ACTH have a common precursor, and that's why you see this hyperpigmentation. Because these people produce excess amounts of ACTH because the body's trying to stimulate the release of cortisol, so that's why you see elevated ACTH. Anorexia, nausea, diarrhea, some non-specific things. Hypotension, that's another important find. So again, if you have decreased amounts of aldosterone, you're not holding on to sodium. That means you're not holding on to water. That means your blood pressure or your blood volume is going to be low, and thus blood pressure. And this can lead to what's known as an adrenal crisis. And this is when that hypotension basically results in shock, okay, vascular collapse. And this is a medical emergency, obviously. So diagnosis based on clinical manifestations, electrolyte levels are important, so you would expect to see hyponatremia and hyperkalemia, and that's due to the lack of aldosterone. And then you administer ACTH, and cortisol levels are still low. So remember, ACTH stimulates the release of cortisol, but if the organ, the adrenal cortex that produces cortisol, is destroyed, injecting ACTH won't do anything. So those are very important finds. And then treatment, hormone replacement, increasing sodium intake to try to increase blood volume, and then treatment for any infection that might be causing the primary adrenal insufficiency. Okay, and then we spent the rest of our time talking about diabetes mellitus. So diabetes mellitus is a metabolic endocrine disorder in which the body either does not produce insulin, or does not produce it correctly, or does not produce it in sufficient amounts, or the body doesn't respond to insulin. So we talked about all of those types. We started with type 1 diabetes mellitus. This is when the cells in the pancreas that produce insulin are destroyed. Those are known as beta cells. Okay, these beta cells are found in these little endocrine groups of endocrine cells known as the islets of Langerhans. So the beta cells are destroyed, and if the beta cells are destroyed, you're not producing enough insulin. So there are idiopathic and immune-mediated types. There are a couple other causes, but most causes of type 1 diabetes are due to autoimmune destruction of these portions in the pancreas. So 80% of beta cells are destroyed before symptoms begin, so that's interesting. So clinical manifestations, the 3 Ps, polyuria, polydipsia, polyphagia. You also see weight loss, you'll see fatigue, prolonged wound healing, paresthesias, and of course all of the acute and chronic manifestations that we'll talk about in a little bit. So when the body does not have insulin, it feels like it's in a starvation state. Okay, so a lot of our body cells need insulin in order to take glucose in, and if they can't take glucose in, the cells feel like they're starving. That's why you see the weight loss, because the body is breaking down fat to try to get some energy. But that also results in problems like diabetic ketoacidosis. So here is one of these pancreatic islets of Langerhans. We have 3 main cells. We have alpha cells, which produce glucagon. We have beta cells, which produce insulin. And then we have delta cells, which produce somatostatin. This is just showing the factors that come together to result in type 1 diabetes. And then type 2 diabetes mellitus, typically caused by resistance of these insulin receptors, so they don't respond to insulin, which of course is bad. But also abnormal secretion of insulin, or if the liver is just making too much glucose, that can also result in type 2 diabetes mellitus, but it's most commonly due to insulin resistance. So, like most of these chronic diseases, it's a combination of genetic and environmental factors that is the etiology. Risk factors, of course, obesity. That's a huge risk factor. Also, increased age. We typically see this, in middle-aged and above when it comes to age, but unfortunately, younger and younger people are getting type 2 diabetes. Physical inactivity, of course, that's related to the obesity, and family history. So clinical manifestations, again, polyuria, polydipsia, polyphagia, paresthesias, fatigue, itchiness, very characteristic diabetes type symptoms. So this is just showing all the possible causes and consequences of chronic hyperglycemia. And I just had this little note that organs like the brain and the liver, they really don't require insulin to take glucose in, which is good, because we don't want the brain to be starved of glucose. So evaluation or treatment of diabetes mellitus. So we talked about these values. Again, these may be different depending on where you look. But type 1 is going to be treated with insulin. These people need insulin. But also, meal planning is also important for type 1 diabetes or diabetics, because, obviously their meal is going to affect blood glucose very rapidly. Type 2 if it can be treated with diet and exercise, that's the best way to go about it. But of course, we have our famous meds like metformin, and some are also treated with insulin. So acute complications of diabetes mellitus, obviously hypoglycemia and insulin shock. So if somebody injects too large of a bolus of insulin, you can have severe hypoglycemia. Symptoms: pallor, tachycardia, tremor, anxiety, confusion, dizziness. All of those things we associate with low blood sugar. Of course, diabetic ketoacidosis, which you see most often in type 1 diabetics. So, like I said earlier, when the body feels like it's starving, it starts to break down fat. That's known as lipolysis. And that the breakdown of those fats causes the buildup of ketones. Ketones are acidic. And since they're acidic, this decreases blood pH. So you'll see patients, at least early on in DKA, they'll be hyperventilating. They're trying to blow off CO2 to raise blood pH. Dizziness, ketonuria, so you'll see ketones in the urine. Nausea, thirst, things like that. And this is a medical emergency. And then we talked about hyperosmolar hyperglycemic non-ketotic syndrome. You see this most often in type 2 diabetics. It's usually a pretty slow developing, over days or so, maybe even weeks, where you have this very high serum glucose, typically over 600, but near normal pH. So bicarb's normal, pH is normal. But it really has manifestations neurologically and needs to be corrected. You often see it when people just kind of don't stick to any sort of diet, and they just kind of go wild for a short while, and this can develop. Then, of course, the chronic complications of diabetes. So you have microvascular diseases. These are diseases due to damage to capillaries. The big ones: diabetic retinopathy, diabetic nephropathy, diabetic neuropathy. Retinopathy, most common cause of blindness, at least in our country in adults. Diabetic nephropathy, most common cause of chronic renal disease. And then diabetic neuropathy, which we're all familiar with, most common cause of neuropathy. And then we have the macrovascular diseases, so damage to larger vessels like arteries and arterioles. So, diabetes patients, they are much more prone to cardiovascular disease. So this includes stroke, PVD, heart attacks, all of those things. And of course, they are much more prone to infection. Okay, and this is just showing some of the manifestations, complications of diabetes. And then comparisons of the types of diabetes mellitus. Okay, the big takeaway: type 1, these people do not produce insulin. They require exogenous insulin. And then type 2, most of these people are resistant to insulin. So adding excess insulin in most cases won't help, but diet and exercise in some cases can actually be curative. So that's a good place to start. As always, if you have any questions, please don't hesitate to ask.